Welcome to today's episode. We're diving into a detailed quiz prep on pediatric gastrointestinal conditions, nutrition, hepatitis, congenital anomalies like cleft lip and palate, esophageal atresia with tracheoesophageal fistula, plus poisoning and lead exposure. It's a rich review for advanced practitioners looking to sharpen clinical reasoning and nursing priorities.
Yeah, it's a solid lineup. Let's start with nutritional risks. Vitamin D deficiency, for example. The highest risk group is breastfed infants with dark skin, living in northern latitudes, with limited sun exposure. That combination, lack of supplementation, melanin-blocking UV synthesis, and low sunlight, really sets the stage for deficiency.
Right, and that contrasts sharply with formula-fed infants or toddlers drinking fortified milk, who usually get enough vitamin D through diet. It's a classic example of how environment and skin pigmentation interplay with nutrition.
Exactly, and iron deficiency is another big one. Infants fed exclusively on cow's milk are most at risk. Cow's milk not only inhibits iron absorption because of its phosphate content, but also can cause occult gastrointestinal blood loss. So it's a double hit.
That's a critical clinical pearl. I like to think of vitamin C as the gatekeeper that opens the door for iron absorption, while milk acts like a bouncer, blocking iron from getting in. So, iron supplements should be given with vitamin C sources like orange juice and between meals, avoiding milk or calcium-rich foods.
Yeah, and antacids also inhibit iron absorption, so timing matters. Moving on to fluid and dehydration. Moderate dehydration in kids is best identified by delayed capillary refill over 3 seconds, indicating poor peripheral perfusion.
Presence of tears and normal cap refill usually means mild or no dehydration. And interestingly, stool losses are the most significant fluid loss in children with diarrhea, more than urine, sweat, or tears.
That's important because it guides fluid replacement. Also, hypertonic dehydration means more water loss relative to sodium, leading to increased serum sodium and cellular dehydration. It's more dangerous neurologically than isotonic dehydration.
So understanding the type of dehydration really shapes how we manage fluids. Now, acute diarrhea in kids is mostly transmitted fecal-orally, which underscores the importance of hygiene.
Absolutely. The priority nursing intervention is rehydration, not antibiotics or fluid restriction. Oral rehydration solution is appropriate for mild to moderate dehydration, typically around 50 milliliters per kilogram.
Right, but for severe dehydration, unconsciousness, or shock, IV fluids are necessary. And parasite prevention is straightforward but often overlooked. Hand hygiene and washing fruits and vegetables thoroughly.
Simple measures with big impact. Shifting gears to appendicitis. The classic symptom is right lower quadrant pain, and pre-op nursing priority is keeping the child NPO to prevent aspiration during anesthesia.
And when we talk about inflammatory bowel disease, Crohn's can affect the entire GI tract from mouth to anus, while ulcerative colitis is limited to the colon. That distinction is key for diagnosis and management.
Definitely. On hepatitis, transmission routes vary. Hepatitis A is fecal-oral, often through contaminated food or water. Hepatitis B and C are bloodborne, with B also spreading via body fluids.
Nursing care focuses on rest and nutrition to support liver recovery, and prevention hinges on hand hygiene and vaccination where applicable. Knowing transmission routes helps with infection control and patient education.
Now, congenital anomalies. Pre-op care for cleft palate centers on feeding support because these infants struggle with suck-swallow coordination. Upright feeding position reduces aspiration risk.
Post-op, avoiding oral suction is critical to protect surgical sites. And for esophageal atresia with tracheoesophageal fistula, the classic triad is coughing, choking, and cyanosis, the 3 C's.
The priority intervention there is continuous suctioning to prevent aspiration and respiratory compromise. Feeding orally or positioning flat is contraindicated.
On obstructive GI disorders, Hirschsprung disease is characterized by failure to pass meconium within the first 48 hours, indicating a ganglionosis and functional obstruction.
And in suspected poisoning, the first action is to call poison control, not to induce vomiting or give antidotes blindly.
Finally, lead poisoning. The most common source is old paint, especially in older housing. Nursing priorities include increasing calcium and iron intake to reduce lead absorption and mitigate toxicity.
That's a comprehensive overview. It really highlights how interconnected nutrition, infection control, congenital anomalies, and toxicology are in pediatric GI care.
Yeah, and the subtle details, like milk's role in iron deficiency or the 3 C's in EATEF, can make all the difference in clinical outcomes.
Exactly. Thanks for joining us in this deep dive. Hopefully this helps sharpen your clinical reasoning and nursing priorities in pediatric GI conditions.
Take care